board-certified consultant and adult cardiologist. The topic that we have chosen for today is highlighting presentations of acute coronary syndrome. Good
afternoon, ladies and gentlemen. Thank you, sir, for that kind words of introduction. And thank you, Student College of Physicians, for inviting me for the lecture. So my presentation is based on acute coronary syndrome. So management of acute coronary syndrome is straightforward. So dual antiplatelets, anticoagulation, thrombolysis, PCI or CABG. You have to use statins, ACE inhibitors, beta blockers, and can be heart failure management and management of rhythm. So, but there can be some difficult cases as well. So let's see the case one. So this 56-year-old male patient coming with chest pain, in the background history of smoking, hypertension, uncontrolled diabetes, and diabetic foot infection. So he was hemodynamically stable, tachycardic, and tachypneic. Physical examination, there's a murmur and a low there's no low limb edema, and there's active wound on the right foot. So ECG shows ST elevations in leads 1, AVL, V2, V6, and treated as acute ST elevation MI with thrombolysis because it was not possible for primary PCI. So thereafter, the echocardiogram was done. So, and found to have mass on the aortic valve. So causing the cause for the murmur. And other than that, there were anterior and lateral wall hypokinesia, mild pericardial effusion, and borderline LVS dysfunction. So, but after the thrombolysis therapy, the coronary angiogram was not done because of the agitation location, because it was protruding into the left main coronary artery. So it can be hazardous when we are performing angiogram. Then the lab findings came. So here's the anemia, elevated WBCs, mild renal dysfunction, elevated CRP, and positive troponins as well. So blood cultures became positive for Staph aureus and was sensitive to these antibiotics. Then 3 days after, the follow-up echocardiogram was done. So there was large aortic vegetation with the root abscess and fistula formation from LVOT, left ventricular outflow tract, to left atrium. And there is another vegetation on the mitral valve as well. And pericardial effusion has grown bigger, causing signs of tamponade. So you can see the aortic root abscess in the first picture. Then the mitral valve as well. I don't have a pointer. So pericardial effusion was aspirated, but the patient deteriorated and then finally passed away. So key points. So the mortality associated with infective endocarditis with myocardial infarction is very high. So what we have to do is, if we suspect something, other than STEMI plus something, so we have to go for the echocardiography. But so in this type of cases, so not straightforward cases, so we have to go for the. So case number 2. This is 62-year-old male with diabetes mellitus, coming with chest pain and sweating. Blood pressure is all right. and the heart rate was 98 per minute. So initial ECG, inferior lateral ST elevation MI, a posterior wall line right ventricular involvement. So echo was done. So it showed hyperkinesis of basal and mid inferior wall with mildly reduced ejection fraction of 45. So patient was taken to the cath lab and found to have right coronary artery total occlusion. So stenting was done, but after stenting, the flow was not that good. So because if the flow is very good, we call it STEMI 3 flow, but STEMI 2 flow. So then because of that, he was treated with adenosine and abscession. So adenosine for the microvascular dilatation. So still the persistent acceleration part. Then after the PCI procedure, the echo showed moderate to severe mitral regurgitation with some posterior lifted tethering. So several days after, he became hemodynamically stable and was discharged. So then again, he came with sudden onset shortness of breath, sweating, and signs of pulmonary edema and cardiac shock. Then the echo was done. So it showed anterolateral papillary muscle rupture with severe eccentric mitral regurgitation. So immediate cardiothoracic intervention was done with valve replacement. But we could not revive the patient and he passed away. So the point is, so this is right coronary artery occlusion, but he came with the anterolateral papillary muscle rupture. Usually the anterolateral papillary muscle is supplied by the left anterior descending artery diagonals and the circumflex. But and the posteromedial papillary muscle is supplied by the posterior descending artery. So this is right dominance, and but somehow because of the anatomical variation, the anterolateral papillary muscle was supplied by the right coronary artery, and because of the ischemia, later anterolateral papillary muscle got ruptured. So go to the third case. It's a 46-year-old woman. So young lady coming with mild chest discomfort. So ECG showed a TVA inversions in anterior leads. So she didn't have any risk factors for atherosclerotic coronary artery disease. So ECG showed ST elevations in anterior leads with increased troponin. Echocardiography showed echinus in apical wall of the left ventricle. So suspect then the differential diagnosis so Takotsubo cardiomyopathy, that is a stress-induced cardiomyopathy, or left anterior descending artery dissection. Then the patient was taken to the cath lab and emergency coronary angiogram was done. So it showed severe stenosis of the left anterior descending artery from mid to distal, and other vessels are normal. So gave intracoronary nitroglycerin DTN, but there's no improvement in the stenotic lesion. Then the intravascular imaging was done with the intravascular ultrasound scan. So it was found there is an extensive intramural hematoma, so causing the stenosis. So then the intervention done with the balloon dilatation, with the cutting balloon. So you can see the on the right hand side, the coronary angiogram. So there's a narrow segment, the descending part. The IVS image on the left hand side. So in the crescent shape area is marked as hematoma. So the black part is actually the probe, IVS probe, black central area. So post procedure there was less stenosis and the coronary flow is good. So what the guideline says is if the in a dissection of coronary arteries, if the flow is good, so you don't have to intervene further. Then patient is all right. Then ECG also there's substantial recovery. So then the follow-up coronary angiogram was done. So there was STEMI 3 flow in LED and the minor dissection. So this is not a typical typical case. So usually we see the atherosclerotic plaques and then the myocardial infarctions. But it's common in young females. So especially we get patients postpartum. So then we generally suspect coronary dissection because of even for postpartum period there is a laxity of smooth muscle also. So other than that, there can be severe stress like hyperemesis, extreme exertion, emotional stress, and some symptomatic drugs. So patient, especially young females with no other cardiac risk factors, we have to suspect this is spontaneous dissection because in that case, stenting is sometimes can worsen the situation because we can go into the false lumen and stent the false lumen, then there will be no reflow. So patient's condition will get deteriorated. So move on to the next case. This is a 47-year-old male with uncontrolled type 2 diabetes, coming with nausea, vomiting, and dizziness. Didn't have chest pain, but there's shortness of breath, cough, no chest pain, shortness of breath, sweating. So physical examination was unremarkable. There's a troponin was high, and serum glucose also high, and sodium was a little bit low. So the ECG was done, and it showed some cord segment elevation in. And other than that, this patient is having previously having right band branch block, and ECG showed V1 cord segment elevation, and V2, V3 also there's ST elevation. So patient was taken to the cath lab and angiogram was done. So before proceeding to the angiogram, patient developed ventricular tachycardia, then leading to ventricular fibrillation. So defibrillation is done, and then proceed for the angiogram. Found to have that stenotic lesion in the proximal LAD and distal LAD. So the possible cause for the VT was we thought it's ischemic, so went ahead with regulating stents. So this is your right hand side, the first angiogram. You can see the descending coronary, the left descending coronary artery. So proximal there's a tight lesion and distally there's a tight lesion. So after the stenting, there's good flow. Then after stenting also, patient developed 2 episodes of ventricular tachycardia, defibrillation is done. So because of that, there was suspicion that he may be having Brugada syndrome as well. So thereafter, he didn't have any further episodes, and he was discharged with a wearable defibrillator. And EP studies was also done, and negative for sodium channelopathy. So then follow PCG, there was disappearance of the Brugada pattern. So only right bundle branch pattern is there. So in this case, he is actually having a STEMI. So pre-existing right bundle branch block and the metabolic derangement because of the uncontrolled diabetes and possible diabetic ketoacidosis. So this is another important presentation, the inverse pattern. 50-year-old male, he was previously well, coming with chest pain for 2 days. So vitals stable. So the ECG, there's precordial is only 1 millimeter ST elevations, and there were some upsloping ST depressions. And we leads with the 2 E6 line with T waves. So precordial is you should have usually more than 2 millimeter ST elevation. So it's only 1 millimeter. So troponins was elevated. So this is actually ECG. It's called a Divinter's pattern. So it's a kind of rare and usually early finding. So as well as a STEMI equivalent. So if there is a Divinter pattern in ECG, so you should treat him as ST-elevation MR. So the coronary angiogram was done, and there's a occlusion of the proximal LAD. So he underwent stenting with drug-eluting stents, and the ECG returns to normal. So because of the early intervention. So the ECG diagnostic criteria: tall, prominent symmetrical T waves in the precordial leads, upsloping ST segment depression more than 1 millimeter at the J point in the precordial leads, absence of ST elevation in the precordial leads, reciprocal ST segment elevation about 1.5 to 1 millimeter in ABR, and a typical STEMI morphology they can develop thereafter. So it's very important ECG findings, and so common risk factors: males, mean age of 52 years, history of smoking, hypocholesterolemia, and uncontrolled hypertension, and family history of myocardial infarction. So this case number 6. So ST elevation, myocardial infarction without culprit lesion. There's a 54-year-old male, heavy smoker, long-term treatment with losartan and amlodipine for hypertension. Came with severe central chest pain 6 days before hospital arrival. So initial diagnosis, ST elevation, myocardial infarction. So you can see the ST segment elevation in lead B2 to B5. So he was given stat doses and taken to the cath lab. So when he arrived to the cath lab, the pain was no more there. And the ECG ST elevation settled. Anyway, the coronary angiogram was done, so it showed diffuse epicardial atherosclerosis and stenosis in multiple arteries. And left ventriculography, there's hypokinesia of the left ventricular apex. So, because of his presentation, there's no culprit lesion was found, and because of the triple lesion, and the acetyl choline test was done. So, intracoronary acetylcholine was given. So then, patient developed severe chest pain with STL segment elevation in anterior leads, with occlusive epicardial spasm in LADR second diagonal. So usually, if the coronary arteries are normal, with the infusion of acetylcholine, the nitrates will be released from the bones, and there will be coronary dilatation. But in the disease, coronary arteries, there will be spasms. So the intercoronary nitroglycerin, there's reversion of ECG and symptoms. So then the PCI procedure is sending to the left anterior descending artery and the diagonal. Then post procedure, again the acetylcholine challenge was repeated, but there were mild symptoms and no epicardial spasm with no ST segment elevation. So this is another entity. So patient can have coronary spasms as well without any the culprit lesion. So and we can put the patients on nitrates, so can prevent the symptoms. So the last case, I think, so patient with SLE, systemic lupus erythematosus, so 37-year-old female with a history of SLE. She stopped the medication because she wanted to become pregnant. And 6 months back, she has had COVID positive as well. So coming with shortness of breath, cough, loss of appetite, weight loss, joint pains, and general weakness. Vitals were fairly okay, and she the initial ECG showed some anterior MI with QAS. Because while in the ward, she developed chest pain and background troponin rise. She was referred to the cardiologist. So echo showed dilated left heart with a ejection fraction of 30% and decreased artery function. And there's a severe regional wall motion abnormalities and found to have left ventricular thrombus. So coronary angiogram, there's diffuse coronary artery disease with left main involvement. So patients with these inflammatory conditions, they are more prone for getting coronary artery disease. So, but the approach was conservative because thereafter she developed bleeding and anyway, then developed rise of paralysis. So MRI scan showed there's it was infarct and as well as left internal carotid artery thrombus. So probably from the LV. Then she was managed conservatively, discharged on dual antiplatelet, statins, heart failure medication, and SLE medication. So somehow she improved her motor functions. So this is a complex case involving SLE and history of coitality, recent myocardial infarction, and stroke. So in these situations, we have to balance the thrombotic risk and the bleeding risk. Another thing is because she want to get pregnant, and because of that she stopped her medication, and probably this contribute to the this wave presentation. So as take-home message, I like to say that early and acute diagnosis along with tailored interventions are critical in managing atypical presentation of acute coronary syndrome to reduce the mortality and improve patient outcome. Thank you.
Thank you very much, Dr. Gajaweera. All of we don't allow questions, but we can have exceptions. Any observations? Thank you very much for presenting these exciting cases. And the Civil Project officials, if also grateful for you for coming and presenting this excellent lecture. Thank you very much.